proud to present you Supportive Care in Hematology 2021. We have been fortunate enough to put together the scientific agenda under the guidance of our program director, Professor M.B. Agarwal sir. At Emcure, we are not only proud to bring very innovative and affordable molecules in the area of supportive care, namely NCCA 1K, MGRAST-M, and PEGX, but we are also designing cutting-edge scientific programs which will enhance the better patient care. Before we move into the scientific program, I'm really privileged and honored to invite our own president of Emcure India Formulation Business, Mr. Pratin Vete sir, to give his presidential address. Mr. Pratin Vete sir has shown visionary leadership in the Indian pharmaceutical market, and he has been in forefront in driving certain therapy areas across the organization. So with this, I would like to welcome Mr. Pratin Vete sir for his address to all the medical fraternity who has joined for today's webinar. Over to you, sir.
Thank you, Dr. Arvind. I think Emcure takes immense pride to be associated with the Mumbai Hematology Group and the hematology fraternity of the country. On behalf of the Emcure Pharmaceuticals, we would like to thank Professor M.B. Agarwal sir and for being the program director for today's event, along with eminent international faculty, Professor Dr. Heinz Ludwig, and all hematologists for accepting our invitation and sparing their valuable time for the meeting. Over to you, Dr. Agarwal. You can take it over.
Yeah. Thank you so much, sir, for your impactful opening remarks. Now with this, I think it is a good idea to learn from you before we actually deep dive into the scientific program. So for this, we have designed a pre-webinar poll questionnaire. These are simple 5 questions which will appear on your screen. And then you just need to select one of the response and click the next button. So now you have a couple of minutes to actually go through the pre-webinar poll and give us your inputs. I can see that audience is really interactive and completing the questionnaire. Yeah. So thank you so much for your response. And with this, now we move into the scientific program. It is my pleasure and privilege to invite our program director, Dr. M.B. Agarwal sir. He doesn't need any introduction. He is the professor and head of Department of Hematology at Bombay Hospital Institute of Medical Sciences, consultant hematologist at Lilavati Hospital, Mumbai. He's a gem of person, and every time we connect with sir, it's a great learning experience for us all. So with this, without a further ado, now I hand over the proceeding to Dr. M.B. Agarwal sir. Thank you so much, sir, for your time and joining us today. Over to you.
Thank you. Good evening to one and all. It's my proud privilege on behalf of Mumbai Hematology Group to be associated with Emcure for conducting this very important webinar on supportive care in hematology. And we're going to discuss 2 very, very important molecules with 2 very great personalities who are going to speak to us this evening. It's my privilege to introduce the first speaker, Professor Dr. Heinz Ludwig. He's Professor of Internal Medicine and Hemato-Oncology and chairs the Wilhelminen Cancer Research Institute at the Department of Medicine 1, Center for Oncology and Hematology at Vienna, Austria. His areas of specific research and interests span the field of therapeutics in hematology and medical oncology. His research specifically focuses on the biological and clinical aspects of multiple myeloma as well as on the analysis of factors associated with anemia and the treatment of anemia in cancer patients. In the early days of his research activities, he was able to show a significant activity of erythropoietin in treating anemia in myeloma. He led several investigator-sponsored clinical trials in myeloma and participated in many studies organized by research-oriented pharmaceutical industry. Within the International Myeloma Working Group, he has contributed to several position papers and in some of them as lead researcher. Presently, his team is evaluating the role of certain signal transduction molecule inhibitors in myeloma cell lines and myeloma-bearing mice. Furthermore, he is running academic trials with ixazomib and with carfilzomib combining regimen and is participating in several international studies. He serves as peer reviewer of several international journals and has published many scientific articles. He is a strong supporter of patients' interests and patients' rights. Under his initiative, an international charter of cancer patients' rights has been published under the auspices of ESCO, the Chinese Society of Clinical Oncology, and ESMO. He has served as president of ESMO and on the board of international directors of ESCO. At present, he is a member of the board of the International Myeloma Foundation and president of the Austrian Forum Against Cancer. For his scientific contributions, he has been honored with the Robert Kyle Lifetime Achievement Award, the Otto Keller Award, the Golden Cross of Merit from the Republic of Austria, and the Golden Cross of Merit from the city of Vienna. So it's great pleasure, sir, to invite you. Now I hand over the reins to you to speak to us about the importance of parental iron therapy, FCM, in treating anemia of cancer. Over to you, sir.
Dear Professor Agarwal, dear colleagues, it's my great pleasure and privilege to share with you our data on anemia in patients with cancer, and subsequently I will talk about the use of ferric carboxy maltose for treating anemia in patients with cancer. I hope you can see my screen. I'm not sure whether that is already in place.
Not yet.
You can share the screen now, sir.
Yeah, I share the screen. And again, I would like to thank Professor Agarwal for his very friendly introduction. Thank you very much. So my topic is the evolving role of ferric carboxy maltose in iron deficiency anemia. But I want to start with a broader view on anemia in cancer. And as you all know, the WHO has defined anemia as hemoglobin of less than 12 in women and less than 13 in men. And when you look at the common terminology criteria for adverse events, anemia grade 2 is defined as hemoglobin between less than 10 and 8 grams per deciliter. Now, in cancer patients, anemia is quite frequent, and there are many causes contributing to anemia in cancer. But the most prevalent one is what we call anemia of chronic diseases. Of course, cancer therapy may impact on erythropoiesis and may induce anemia. There may be blood loss. There may be mechanical, but more important, I think, chemical suppression of erythropoiesis. There may be hemolysis, vitamin deficiency, and importantly, and I will show you data, in quite a substantial proportion of patients, there is iron deficiency. And of course, there are rare complications like TMA and other complications. Now, when we talk about iron deficiency, we should distinguish between absolute iron deficiency, where there is insufficient iron available in the body, so due to inadequate iron intake or chronic blood loss. And this is defined by a transferrin saturation below 20% and ferritin below 30 in people with in normal people, so-called normal people. But in cancer patients, the cutoff is less than 100 nanograms per milliliter. So this is in distinction to what we call functional iron deficiency, where the iron stores are actually full. There's adequate iron available, but the erythropoietic system has no adequate access to iron because it's retained in the iron stores. And those patients are defined with a T-set less than 20%, and ferritin levels are higher. These are normal people, and these are people with cancer or other inflammatory diseases where the ferritin is usually higher than 100 nanograms per milliliter. Now, when you look at other parameters, of course, there is an abundance of hypochromic red cells, particularly in patients with absolute iron deficiency. There's an increased number of hypochromic red cells also in those with functional iron deficiency, but this is usually much lower than in absolute iron deficiency. And what is important, serum transferring receptor levels are much higher in patients with absolute iron deficiency and are normal in patients with functional iron deficiency. Now, we looked at the incidence of anemia in 1,528 consecutive cancer patients, which were seen in our center. And you see here, the red columns denote the proportion of anemia in patients with different diagnoses. And here we have the hematological patients. And you see here, you see already anemia in a small proportion of your patients with MGUS. Of course, more patients present with myeloma, present with anemia. And here you have the leukemia patients, lymphoma patients. And in blue, you see the patients with iron deficiency. And the blue bars represent patients with both functional and absolute iron deficiency. Now, when you ask the question, if there any correlation between anemia and iron deficiency and tumor stage, the answer is quite clear-cut, yes. In solid tumors, you see here the correlation of both anemia and functional iron deficiency with tumor stage. In hematological malignancies, it's a little bit different because there's a correlation between anemia and stage of lymphomas, non-Hodgkin's disease, but there is no correlation between iron deficiency, but there is more absolute iron deficiency as shown here in yellow in patients with advanced stage of hematological malignancies. And the same is true for ECOG functional status. So there is more anemia, there is more iron deficiency in solid tumors with high ECOG stage, and there's more anemia in patients with hematological malignancies with ECOG stage 2 and 4. But functional iron deficiency seems to be, an absolute iron deficiency seems to be equally prevalent in both ECOG 0 to 1 and 2 to 4 groups. Now, the main causes of absolute iron deficiency in cancer patients is due to reduced iron absorption and blood loss. Of course, there may be nutritional iron deficiency, and there may be iron deficiency which is completely unrelated to cancer because of a comorbidity, inflammatory bowel disease, or infections, or hereditary syndromes which are associated with reduced iron resorption. Now, whatever the cause of anemia, if anemia is prevalent, then patients suffer from impairment of physical and emotional aspects of quality of life. Of course, physical impairment is usually shown by reduced cardiorespiratory function, exertional dyspnea, fatigue, and so on, increased pulse rate in case of severe anemia. And even patients with moderate or mild anemia, when you do a history and when you ask your patients about sexual function, you will note that even a small decrease in hemoglobin may have a significant impact on the quality of their sexual function. Now, this is also shown nicely in a study which looked at the productivity of Indonesian rubber tappers, there was a close correlation between hemoglobin levels, because those who did had a high or normal hemoglobin level were more productive. So showing the impact of anemia on physical functioning and emotional functioning and other aspects of quality of life. Now, when you improve anemia by treatment, you see an impact on quality of life, and these are data from Littlewood. So the greater the impact the greater the increase in hemoglobin from less than 2 grams, you see here, or more than 2 grams, or 2 grams and more, you see here a significant improvement in quality of life in patients with a significant improvement in hemoglobin levels. Now, what are the treatment options which are available today for patients with anemia, for cancer patients with anemia? The old traditional one option is, of course, blood transfusions. We have erythropoietins, and now we have intravenous iron preparations. What is the benefit? Blood transfusions are indicated for patients, and we'll talk and discuss it in greater detail, who are in need for a rapid improvement in hemoglobin levels, but they have a short-term effect and are associated with several risks. Erythropoietins are indicated in patients with anemia undergoing chemotherapy and presenting with hemoglobin of 10 or less. It takes some time to show improvement, and only 1/3 of patients show improvement. And this is completely different to intravenous iron preparations, but particularly to the newer one, the carboxymaltose, ferric carboxymaltose preparations, which lead to a faster increase in hemoglobin as compared to erythropoietins. They show a long-term effect and are usually very well tolerated. There are rare episodes of transfusion reactions. Now, let's talk about these options in greater detail. Red blood cell transfusions are the treatment of choice if rapid increase in hemoglobin is needed. And that is true. They are also effective in non-responders to erythropoietin. But there are many caveats shown here. First of all, they can induce adverse immunological reactions, anaphylaxis, transfusion-related acute lung injury, purpura, graft versus host disease, and they may be associated with transmission of infectious microorganisms, also including Jakob-Creutzfeldt disease. And patients who receive transfusions have a higher infection rate. So the infection rate is 4 to 8 times higher in patients who receive allogeneic blood. There's an increased risk for tumor recurrence that has been shown for patients with colorectal cancer. There's an increased risk for thromboembolic complications. And of course, all the storage of blood can be stored up to 30 days. And the longer the storage time, the lesser the quality of the red blood cell transfusion product. And it may induce secondary primary malignancies. This has been shown in patients with CLL and may be associated with increased morbidity, and is associated with increased morbidity, and may be associated with increased mortality. Now, erythropoietins, they are somewhat a physiological therapy in patients with inadequate erythropoietin production. And if patients respond, responses can be maintained sometimes for months, and you can combine erythropoietins with iron, IV iron, to enhance the activity and increase the response, the erythropoietic response. But there are also several cons shown here. They are associated with an increased rate of thromboembolic complications, there's an increased risk for hypertension. And ASA use needs to be restricted to approved indication, meaning that ASA use is only indicated in patients with concomitant chemotherapy. And if you treat ASAs, your patients with up to a hemoglobin of 12 and even higher, in certain diseases like in head and neck cancer, you may enhance tumor progression. So you have to be very careful and stay within the indication. The indication for iron therapy are quite clear-cut. Oral iron therapy is indicated in patients with iron deficiency if they have no inflammatory, let's say, no extensive inflammation ongoing. But cancer patient or cancer per se is usually associated with increased inflammatory production of inflammatory cytokines, which impact and impair the enteral absorption of iron. Hence, in the cancer, you usually need to use intravenous iron preparations, and you can use them as sole anemia treatment. You can use IV iron after failure to respond to ASAs, and you can use IV iron together with erythropoietic agents. What are the benefits? IV iron works in patients with anemia of cancer and inflammatory conditions, and in both in patients with functional and those with absolute iron deficiency. It provides iron to patients with functional iron deficiency. It results in relatively rapid increase of hemoglobin and has a positive impact on quality of life. Of course, there are some cons. You need to administer IV iron, of course, intravenously, and rarely it may be associated with infusion reactions. Now today we have several intravenous iron preparations which we can select for choose for treatment. Here you have preparations using gluconate or iron sucrose, and these preparations are well tolerated, but the disadvantage is that they have a relatively short half-life. The half-life is much longer for ferric carboxymaltose, which probably explains also the higher activity. And as you see here, their use is quite safe because there is no reactivity with antidextran antibodies. You have this reactivity with the other preparations shown here on the right side. So those preparations probably, at least we avoid to use those preparations because there's an increased risk for anaphylactic reactions. Ferric carboxymaltose is a stable, robust complex. It's formulated as a colloidal solution. It comes with a physiological pH and can be administered, and that is another advantage to all the other preparations, in high doses up to 1,000 milligram during a single administration, which is, of course, improves patient comfort and probably also the healthcare utilization of healthcare resources and so on. Here we have the molecule of ferric carboxymaltose. You see here the carboxymaltose shell, and that is very important. And here you have the iron. And when you infuse this ferric carboxymaltose, it's taken up by macrophages. Then it is delivered to lysosomes, and where it is cleaved, and then iron is then exported via ferroportin. It then transferred into trivalent iron and then coupled to transferrin, which is the transport protein for iron and which brings iron to the erythroid marrow. And that the specific formulation of ferric carboxymaltose is important because it reduces the release of free iron, which can catalyze the production of highly toxic hydroxyl radicals. So it's very safe. Iron carboxymaltose is safe, much safer as compared to the other products which are available. Now, I think the most convenient dose is an intravenous iron drip infusion. We usually use 1,000 milligram per single infusion, but of course you should not exceed the recommended dose of 0.3 milliliter of ferric carboxymaltose per kilogram body weight at a single administration, and you can administer ferric carboxymaltose in weekly intervals or in longer intervals. So usually you can use intervals up to 3 weeks and then look at the results, and if the result is appropriate, then you can discontinue treatment for a while. Now, what are the results which you obtain with ferric carboxymaltose in anemic patients with cancer? This is a study which has been published by Hedenos, and these are patients with lymphoid malignancies, as you see here. These are the control patients, and these which did not receive anemia therapy, and these are the patients which received 1,000 milligram ferric carboxymaltose. And if they were if they had less than 50 kilograms, the dose was only half dose was used. And you see here the nice improvement in hemoglobin, the constant improvement over 8 weeks. And these are the intent. This is the intent to treat population, and this is the protocol population. The next slide shows you similar results from a field study. And that is interesting because Dr. Steinmetz treated patients with cancer-associated anemia, and they received 1,000 milligram ferric carboxymaltose, either alone or with erythropoietic agents. And you see here in red, these are the patients who received ferric carboxymaltose plus erythropoietic agents, and the patients shown in this blue color received ferric carboxymaltose only, and the improvement was similar or was equal in both groups. So in other words, ferric carboxymaltose was efficient, and there was no need for additional erythropoietic agents. And you see here, depending on the starting point, these were patients with more severe anemia, which were enrolled, and these are patients which we usually won't treat, but Dr. Stein has treated those patients, and they experience also some improvement in hemoglobin levels. Now, and that is very interesting because that is something probably many people, many colleagues, and I must say I myself didn't expect that that will happen, because these were patients with chronic heart failure, NYHA stage 2 and 3, and iron deficiency, functional iron deficiency, and they were randomized to either 200 milligram ferric carboxymaltose weekly until correction, then 4 weekly, and until correction of iron deficiency, or placebo. And here you see the results. You see there is a significant improvement in global quality of life. NYHA functional class was improved, and the 6-minute walk test was significantly improved by just giving IV iron in patients with chronic heart failure and functional iron deficiency. And you here see the AQ5 dimension quality of life scale, again, significant improvement in quality of life, not in patients with cancer, but in patients with cardiac disease, but with functional iron deficiency. Now, when you look at the guidelines, these are the ESMO guidelines for management of patients with anemia. If hemoglobin is between 10 and 11, you should ask yourself if the iron deficiency available, if iron deficiency is present, if yes, administer IV iron. If vitamin deficiency is present, of course, you will treat with vitamins. If there are other causes of anemia, of course, you will try to correct them. But this is the target group. Again, if there is absolute iron deficiency in patients with hemoglobin less than 10, you will, of course, administer IV iron and will usually see a nice improvement in hemoglobin levels and also in quality of life. If there's functional iron deficiency, you may use both iron plus erythropoietic agents. And if there is no iron deficiency, then you should use erythropoietic agents, but only in those patients with concomitant chemotherapy. But if the response is inadequate, you add IV iron, and then in most cases you will see a very significant increase in hemoglobin levels. This leads me then to my conclusion slides. Iron deficiency is frequent. It's a frequent complication in cancer. It is associated with functional and motion impairment in cancer patients, but also in other people. The cause of iron deficiency needs to be clarified. No question, IV intravenous single agent iron results in increase in hemoglobin and improves symptoms and quality of life. Treatment with IV iron in combination with erythropoietic agents results in a higher response rate, faster response, and sparing of ASA dosage. Newer iron preparations are well tolerated. Long-term safety data in cancer are not available as yet, but those from renal patients are very, very reassuring. And when it comes specifically to ANC-CARB, ferric carboxymaltose, it is effective and it uses rapid responses, is well tolerated. There is no need for a test dose. There is no gastrointestinal intolerance as compared to oral iron. It's very easy to administer. It seems to be cost effective, and up to 1,000 milligram ferric carboxymaltose can be given in a single administration, resulting in greater patient comfort and probably sparing of healthcare utilities. With that saying, I would like to close and thank you for your attention. First of all, greetings from Vienna, and again, thank you for your attention. Thank you very much.
Thank you, Professor Ludwig, for a very crisp and very, very important talk on this subject. We have collected some of the questions for you, and I'm sure you will enjoy answering them. One question is about calculating the dose of intravenous FCM. In patients of cancer, do you follow the same formula like in iron deficiency?
Actually, we are very pragmatic. If there is functional iron deficiency, we just administer either depending on patient weight, 500 milligram ferric carboxymaltose, or if the patient is weighs more than 50 kilogram, 1,000. I think you can, of course, calculate it more using the different formulas, but for clinical practice, I think that's completely okay.
Right, sir. Another question is about in people who are very obese, can you go up to 2 grams of the dose? That is 1 gram twice or 500 4 times?
There is no good data available. I would restrict the dose to 1,000 milligram and check the response. And I'm probably in most of your cases, even if the patients are obese, you will see a response. And I don't think there is, at this point of time, any data which would motivate us to use a higher dose. I would restrict the dose to 1,000 milligram.
Thank you, sir. Another question is, when do you start testing the hemoglobin after giving 1 dose of IV FCM?
I think this depends on how frequently you see your patient. Actually, you can do it weekly, but I think it would be nice to test your patient after 2 weeks. And you should also look at the reticulocytes, because even if the hemoglobin is just on the rise, you see already the reticulocytes going up, and so that is more or less secure sign that the treatment is working.
Thank you, sir. Another question is about the pediatric oncology patients. Is IVFCM safe?
I think it is safe. I'm not a pediatrician, but what I know, I think is it's safe. But then I think you need to be more careful regarding the dosing. Yeah.
Thank you, sir. Another question is, what is the level of ferritin above which you will not consider giving IVFCM?
That's an important question. Thank you very much. There's no good data, but you can administer ferric carboxymal dose in patients with ferritin 700, no question. But there are some patients coming in with ferritin of 2,500 or even higher. So ferritin in those patients is not only a marker of iron load, but it may also be a marker of tumor load because some tumor cells produce ferritin. So I would be a little bit hesitant to use IV iron in those patients unless there's a significant decrease in transferrin saturation. If transferrin saturation is very low, then we have to accept that the higher levels of ferritin are rather a reflection of tumor progression and high tumor load, and then you can still go on. But I would investigate these patients very carefully before coming to a positive decision.
Thank you, sir. Another question is whether there is any risk of increased infection following intravenous iron therapy.
No, I don't think there's any risk, and that is more data available from patients with renal insufficiency, which receive iron very frequently, and also carboxymal dose iron, and there are no data showing significant an increased risk for infections.
Right, sir. One question is about the diagnosis of iron deficiency, as
Aha.
ferritin is a acute phase reactant.
Yeah.
And serum iron studies are not reliable. How do you make a diagnosis of iron deficiency in cancer patients?
Yeah, that is also very important. So iron is suppressed because patients with cancer have increased production of cytokines. So iron is low. And ferritin is increased not only because in those patients. So then there is a convention that ferritin can be as high as 100. So the most important parameter is transferrin saturation, which should be below 20. And then depending on absolute or relative functional iron deficiency, ferritin is higher than 100 or less than 100. It's not in normal people, you would say ferritin, the cutoff is 30. But in patients with inflammatory diseases, and cancer belongs to those category, the cutoff is 100. Yeah.
Thank you, sir. Question is related to hepcidin. Are hepcidin levels to be estimated in clinical practice?
In clinical practice, no. Hepcidin is increased in those patients, and that is the major cause of reduced enteral iron resorption, and that is also the major cause of reduced iron release from the reticular endothelial system. So then that stimulated several, let's say, groups to try to reduce ferritin levels. Actually, we did a study with what we call a Spiegelmeer, which which intends to neutralize hepcidin levels. And when you reduce or neutralize hepcidin levels, you improve iron absorption and iron release, and actually thereby you should, in theory, improve erythropoiesis. We did only a small phase 2 study, and there are other drugs on the horizon which target hepcidin as main culprit of these disturbances of iron resorption and iron release. Yeah.
Thank you, sir. Another question is related to, is there any specific interval required between chemotherapy and IV iron therapy?
No, there is no specific interval required, but we usually try to avoid giving both drugs on the same day. There is no good data, but we do this just because we think it might not be a very good idea to give it concomitantly on the same day. So that is how we do it.
Another question is whether you need any prophylaxis to prevent reaction to IV FCM.
This is not needed. If you give ferric carboxymaltose, if you have a patient who has, let's say, allergic diathesis, as we say, who has, let's say, allergies against bees and several other products, you may consider this, and you may use a low dose glucocorticosteroids, for instance, 20 milligrams prednisone before you give a shot of ferric carboxymaltose.
Thank you, sir. There's a question away from cancer. In hereditary hemorrhagic telangiectasia with recurrent iron deficiency, at what frequency can you keep giving FCM?
I'm not a specialist in this disorder, I must say, but I would orient myself on the iron parameters, on transferrin saturation, and also on the erythropoietic response, and dose accordingly. And that may mean that I will look at the intervals carefully, but actually I don't see any risk because there is no you will stop as soon as you have your erythropoietic response anyway, and then follow your patient, and then probably restart therapy. Yeah.
Thank you, sir.
Yeah.
Are there any indications to give oral and intravenous iron together?
No, I don't think so. Because you give intravenous iron because the data show you that oral iron will not be effective. And as we all know, oral, it takes quite a long time to absorb enough iron in those patients. And in cancer patients, iron absorption is, gastrointestinal absorption usually is impaired. So it won't work. It will work in cancer patients which have just, let's say, squamous cell carcinoma of the skin or so, which don't have a high cytokine reaction, but then you have to wait for long until you get your response, until you are able to absorb enough iron from the gastrointestinal tract. So it takes 2 to 3 months or whatever. Yeah, but that is, yeah.
Thank you, sir. That was the last question. So
okay.
I'm extremely grateful to you for enlightening us on the use of IV FCM in patients of anemia of cancer, and also giving very basic aspects of anemia together with and answering so many questions.
Thank you.
Thank you so much, sir, for sparing your time.
Yeah. Thank you, Professor Agarwal. Thank you for inviting me, and thank you for having me with you in this distinguished meeting. Yes, thanks so much.
Thank you. Have a great day.
Thank you. I say bye-bye.
Bye-bye, sir.
Bye-bye.
We move on to the second guest speaker of this evening, and we have Dr. Priyanka Samal. She is Professor and Head, Department of Clinical Hematology, Hemato-Oncology, Stem Cell Transplantation at IMS and SUM Hospital, Bhubaneswar. She has been our faculty for a large number of webinars. She has been always very, very active, even as a discussant. So over to Dr. Priyanka, and she's going to tell us all about GM-CSF.
Thank you, sir. Thank you for the opportunity over here to have me as a speaker for the GM-CSF, and thank you and the team from Emcure. Yeah, are my slides visible?
Yes.
Yes. Can you make it full screen?
Yeah.
Thank you.
Visible, right?
Yes.
So after a very lucid lecture about the intravenous iron preparations in patients with cancer as well as in anemia of chronic disease. The next thing we will move over is to the role of sarmograstin, that is sargramostin, that is GM-CSF, tongue twister definitely for me, in hematological malignancies. So we will be going through how it acts upon, what are the advantages of this using of the hematopoietic growth factor, especially GM-CSF in patients with hematological malignancies. So to start with, we have the most important 4 factors which we name as the hematopoietic growth factors or the hematopoietins, and these include G-CSF, which regulates the neutrophil production, GM-CSF, which enhances the production of neutrophils, monocytes, and eosinophils, erythropoietin, which we already discussed about in the previous session, regulates the red cell production, and thrombopoietin, which controls the platelet production. So to start with, what's the biology of the CSF or the colony stimulating factors? These are type 1 cytokine receptors, also called the hematopoietins. They regulate the development, differentiation, and activation of the hematopoietic as well as the immune cells, because together they form the cellular component of the blood. The receptors are type 1 membrane proteins, and they have an N-terminal extracellular and a C-terminal intracellular orientation, which is very much important for the physiology of these chemokines and the chemokine receptors. So to start with, this is the ligand, that is the cytokine, and this is the cytoplasmic membrane along with the receptor over here. So when both of them come together, that is the ligand binds to the receptor, there is dimerization of this molecule. Along with it, the downstream pathway gets activated, which forms the that is the JAK start pathway. And once the JAK comes in contact with this receptor, there is phosphorylation of the residues which are present downstream, as a result of which there is STAT activation. So there are a number of STAT molecules, and JAK start pathway, as we know, is very important in regulating the downstream activation and the signal transduction which occurs in the nucleus. So once these STAT molecules are activated by the phosphorylation, they are translocated to the nucleus, and in the nucleus, they go and bind to the DNA, resulting in the transcription of the important genes and bring about a cytokine response. So this is how the activation occurs. So once there is an activation, there is differentiation in the downstream pathway. Similarly, we must also know how there is loss of function of this cytokine receptor interaction. So in those cases, there are again STATs triggered, and we have some of the important molecules like the SOX, and there are a number of molecules like SOX1, SOX3 up to SOX5. And these proteins are very important to deactivate the interaction of the cytokine as well as its the ligand as well as its receptor. So here we can see that CD45 is also a transmembrane phosphatase that inactivates this JAK. And JAK, not only with the CD45, but the SOX, which also inactivates the JAK and the STAT pathway, result in the proteasomal degradation of the SOX-associated molecule, and that is how we lose the action of this activation of the cytokine through its receptor. So understanding the mechanism of how it activates as well as how it gets deactivated is equally important, because this is what maintains the balance of differentiation and proliferation of these cells. So next we see how there is maturation of these myeloid progenitors. So this is the hematopoietic stem cell. Then we have the progenitor cells, the colony forming units. Then is the granulocyte forming units, the myeloblast, then the promyelocyte, myelocyte, metamyelocyte, band cell, and the mature neutrophils. So normal differentiation of the myeloid progenitors into neutrophils in the bone marrow as well as in the peripheral blood occurs. And as we know, in hematological malignancies, wherever there is a maturation arrest, we find the patients, because of the mutation, they develop malignancies or leukemias, and the leukemias which may be lymphoid or the myeloid leukemias. So similarly over here, the cytokine regulation, as we see, this is the most pluripotent hematopoietic stem cell. From there you see that there is a granulocyte forming progenitor and the lymphoid forming progenitor. That is the common lymphoid progenitor, and this is the granulocyte and the monocyte, as well as the other granular cells which are present in the body. So after that, the first portion is taken up by the interleukin 3, which is a very important cytokine which results in the differentiation of this pluripotent stem cell to a lymphoid and the granulocytic progenitor. But after that, you see there are GM-CSF. Here you can also see the GM-CSF, which further results in the differentiation of the common progenitor, which is after the commitment to the granulocytic lineage. So here also you see that the GM-CSF is a very, very important factor in normal human physiology to bring about the differentiation or the maturation of this granulocytic progenitor cells. So to mention, this was a very good article which I found in the Nature journal, which demonstrates the milestones of the history of severe congenital neutropenia. Actually, these were the landmark findings which resulted in further development of the granulocyte colony stimulating factor as well as the GM-CSF. So as we see, cyclic neutropenia was first recognized as an entity in 1910. After that, in 1922, it was recognized as agranulocytosis or the School syndrome. 1956, the Costman syndrome, and a number of developments as well as the mutations have taken place further downstream. And in 2021, we see that we have a lot of the GCSF as well as the GM-CSF with us to combat these neutropenias, not only in the congenital deficiencies, but also in the acquired deficiencies and while treating our patients of hematological malignancies. Important to note over here is recombinant human GCSF, filgrastim and linograstim was cloned and produced in E. coli in 1985 and became available for clinical research in 1987. US FDA approved GCSF for the treatment of congenital neutropenia in 1993, and since then we have never looked back regarding neutropenia management of the neutropenia. So what is the source of the GM-CSF in us? It is from the macrophages, from the monocytes, by the fibroblast, as well as the endothelial cells. So once we looked at the history of how there was a development of the GCSF, then came the approval of the FDA for the filgrastim, and there is a comparison table with the FDA-approved indications for sarcramostim. So for filgrastim, we have accelerated neutrophil recovery in patients receiving myelosuppression, accelerated neutrophil recovery after the AML induction or consolidation therapy, accelerate neutrophil recovery in patients with marrow transplant, be it autologous or in allogenic, mobilize the peripheral blood stem cells, severe chronic neutropenia, which may be idiopathic, cyclic, or it may be congenital. Similarly, for GM-CSF, it reduces the risk of death due to infection in patients more than 55 years old undergoing induction chemotherapy for AML, mobilize the autologous peripheral blood stem cells, promote neutrophil recovery after transplantation, improve the neutrophil production in patients with delayed engraftment or graft failure after autologous and allogenic bone marrow transplantation. So these are the indications which have been approved by FDA. And as of 2019, the US market share distribution of hematopoietic growth factor shows that 56.5% of the patients receive PEG filgrastim because this is easier to administer single shot, and it can be the activity remains for a prolonged period of time. So that is more convenient and can be taken as an OPD basis or at home. And then you see it is the filgrastim, and the sarcramostim is only 2.3%. So similar is that I did not find any data from Indian registries, but similar is the data I suppose in our day-to-day use as well. So what are the structural differences in recombinant human GM-CSF? It says it differs from that of the native GM-CSF by a single amino acid substitution at position 23. And this is what makes us different from the one we have in vivo and the one which we have in vitro. So there are two types of GM-CSF, recombinant derived from the yeast, which is the sarcramostim, and it is FDA approved for clinical use. There is one which is recombinant form derived from the E. coli, which is known as the molgramostim, but it is not FDA approved. So we have sargramostim available with us for our use in clinical practice. So again, if we look at what are the differences between the G-CSF and the GM-CSF, filgrastim is relatively a small molecule produced in the E. coli, which is not glycosylated. Whereas GM-CSF, a mixture of three molecules having a weight of 19.5, 16.8 and 15.5, it is glycosylated and it is produced in S-cercosis, Saccharomyces. So GCSF receptor is a homo-oligodimer, whereas GM-CSF receptor is a hetero-oligodimer. And it shares a beta chain with the interleukin 3 and the interleukin 5 receptors. And as a result of which, you know that interleukin 5 is very much important in the eosinophilic differentiation and activation. So GCSF receptor is expressed primarily on the neutrophils and the bone marrow precursor cells, whereas the GM-CSF receptor is more widely expressed and it is present on the neutrophil, monocytes, eosinophils, dendritic cells, basophils, and possibly the B cells. G-CSF is the dominant CSF released from the lung cells in response to pro-inflammatory cytokines, and therefore there are a number of literatures which says that whenever we are using G-CSF, there might be a probability of having a lung injury as well, which does not occur, which does not happen with the GM-CSF. So what is important is glycosylation adds stability and degradation resistance. So that is what makes these GM-CSF a more stable entity. So this is what we have already discussed, but one thing to point out is GM-CSF is not essential for hematopoiesis is confirmed by the demonstration of normal complete blood counts and normal number of marrow progenitor cells in the GM-CSF knockout mice. That means apart from GM-CSF, there are also a number of other cytokines as well as the interleukins which play a part not only in the differentiation but also in the maintenance of the stem cells and the progenitor cells. So how does, apart from increasing the number of the granulocytes and the monocytes or the macrophages, how does this enhance the immune stimulation against viral, bacterial and the fungal infections? It is important to know that neutrophil has an antibacterial activity, monocytes have an antifungal activity as well as antitubercular activity in our Indian setting. The macrophages and the dendritic cells, which are also stimulated as a result of the GM-CSF, they bring about antigen presentation to these T cells as a T cells, which along with the B cells activation or stimulation result in the humoral immunity producing antibodies which have antiviral activity as well as anti-tumor activity. So apart from GCSF, GM-CSF also has some immune stimulation action against the infections. So we have discussed for the neutrophils, GM-CSF enhances the chemotactic and the phagocytic activity of neutrophils and extends the neutrophil survival. For the macrophages, we saw that it augments the activity of the macrophages to phagocytose and destroy the bacteria as well as the fungi. The dendritic cells, which are the antigen presenter cells, they link the GM-CSF links the innate and the adaptive immunity by inducing the growth and maturation of these antigen presenting myeloid derived dendritic cells. So that is how the after that the B cells and the T cells get activated and produce the antibodies against the virus as well as the tumor cells. So pharmacokinetics are important to understand what is the ideal mode of administration of any of the drug. So we have GM-CSF, which can be administered as IV formulation as well as in the subcut administration. I have some of the slides which show what is the dosage. It is, I think, after the 2 or 3 more slides. So here you see that IV administration, the half-life is 60 minutes, whereas the subcut administration, it is much more, 162 minutes. The Cmax is 5, over here it is 1.5 on the subcut administration, and therefore, because IV is a more tedious process and the patient needs a needle to be put in his vein for a long time, most of us prefer the subcut administration, and it has also been approved by FDA. So how about the dosing of the GM-CSF? So for the various indications, the dosage is a little bit different, and it is up to the physician's discretion based upon the weight of the patient and what are the indications we are using for the GM-CSF. We are using the GM-CSF for the patient. So for neutrophil recovery following chemotherapy in AML, dosage is 250 milligram per meter square per day. It can be IV over a 4-hour period. As we said, it is approved by FDA both for the IV as well as the subcut administration. Mobilization of the peripheral blood progenitor cells, IV over 24 hours it has to be given, or subcutaneous once daily dose. Post-peripheral blood progenitor cell transplantation, 250 microgram per meter square per day, administered by IV over 24 hours. Important to mention that in cases of mobilization as well as post-transplantation, it is IV over 24 hours or it can be subcut once daily. Myeloid reconstitution after ASCT, it is IV administered over 2-hour period, beginning 2 to 4 hours after the bone marrow infusion and not less than 24 hours after the last dose of chemotherapy or radiotherapy. Important bone marrow transplantation failure or engraftment delay, 250 microgram per meter square per day for 14 days as a 2-hour IV infusion. The dose can be repeated after 7 days of therapy if engraftment has not occurred. So though we see that these are the FDA approval and the doses which are to be given IV in our daily practice, hardly we use this IV formulations because the subcut is much more easier as well as user friendly and patient friendly. So number of guidelines are there, ASCO guidelines, the ASH guidelines, as well as the ESMO guidelines. I have chosen the ASCO guidelines because it has pointed out all the indications and the recommendations as well as the conditions where it is not recommended. So to summarize it, the general circumstances is febrile neutropenia most common indication in the range of wherever the malignancies or in cases where the febrile neutropenia risk is in the range of 20% or higher, we use this as a prophylaxis. Special circumstances according to the use. Secondary prophylaxis, we have some slides on that. Therapy of febrile neutropenia, this is known as tertiary use of the growth factors, and this is the therapy for a febrile neutropenia. Routine use is not recommended, only if the patient has suffered, then only you start with. Febrile neutropenia is high risk for complications or poor clinical outcomes. AML, more than 55 years. G-CSF, you can give it even in younger age patients, but for GM-CSF, FDA approved more than 55 years old, most likely to benefit. Even in MDS, this is not recommended as a frontline therapy being used in neutropenic patients. ALL, after the completion of initial chemotherapy or first post-remission course, radiotherapy, older patients, pediatric population, G-CSF use in children with ALL is not recommended in most of the pediatric protocol for ALL because of the intention to cure in these patients. However, primary prophylaxis of pediatric patients with a likelihood of febrile neutropenia and the secondary prophylaxis of therapy for high-risk patients can be used and it is recommended by these societies. So we have already discussed the primary prophylaxis means there is a high risk of febrile neutropenia more than 20%. Primary prophylaxis should be given with dose-dense chemotherapy where high doses are given at a very short interval of time. Secondary prophylaxis after a neutropenia-related event has occurred generally is recommended if reduced dosing or dose intensity will compromise the disease-free or overall survival. So whenever we are thinking of a cure or an intent to cure chemotherapy, we have to go for a prophylaxis of these growth factors so that we maintain the chemotherapy schedule. So next is the risk factors for chemotherapy-associated neutropenia. These are again the guidelines of ASCO and its complication, which says that age more than 65 years, previous chemotherapy or radiation therapy, bone marrow involvement of the tumor, pre-existing neutropenia, infections, open wounds or recent surgery, poor performance status, decreased renal function and liver function, because these are the conditions which will take the patients to MODS if the patient is not engrafted with his neutrophils at the earliest following any chemotherapy or definitive therapy for the underlying malignancy. So these are the risk factors for chemotherapy-associated neutropenia, and in these cases, we have a definitive role for the growth factors. So GM-CSF, so now going to the definitive malignancies of hematology, GM-CSF in AML. These are the latest guidelines from the ASH 2020. So many studies have shown that the use of myeloid growth factors sensitize the leukemic cells to increase the effectiveness of chemotherapy and prevent infectious complications. So although these shorten the duration of neutropenia during the induction phase of therapy, neither consistently reduce the occurrence of febrile neutropenia, infection, or the duration of hospitalization. This has been proved many a times, and often we know that in spite of the use of these GCSFs in our routine practice while treating patients of AML, we do not find a decrease in the occurrence of the febrile neutropenia, infections, or the hospitalization stay. It results for the GM-CSF use results from the sensitization of the leukemic the leukemic cells to chemotherapy, which is also, this result is also not consistent. Hence, the use of the myeloid growth factors in this way is not recommended except for research purpose. So, induction phase, most of the clinicians in the pediatric population do not use growth factors until the patient becomes hemodynamically unstable, because we do not want to stimulate the blast in the marrow. However, during the consolidation phase of the treatment, when the marrow is responsive and we know that it has been cleared from the blast cells, we consider GM-CSF prophylaxis in these patients, and last randomized trials have shown that there is a significant decrease in the duration of severe neutropenia, decrease in infection, decrease in the requirement of antibiotics, no consistent favorable or detrimental impact of GCSF or GM-CSF on treatment response and survival has been observed. There are concerns that use of these growth factors in the AML induction or the consolidation period might provoke secondary malignancies or secondary leukemias. However, there is no consistent observation to it. So during the consolidation phase, it is safer and it is indicated to use GM-CSF and GCSF in AML patients on therapy. So the next is the ALL, acute lymphoid leukemias, more common in the pediatric, but in adult population also it is common. And 8 randomized controlled trials, including more than 700 adults and children, demonstrate that neutrophil recovery is accelerated with myeloid growth factor, mostly using the GCSF and improving the overall treatment outcomes. So another very important part as hematologist, we would say, is while we take up the patient for an autologous or an allogeneic stem cell transplant. For autologous transplant, we can see that in the steady state, there are fewer number of the progenitor cells in the marrow. They are present usually in the marrow niche. And from the marrow niche, we try to stimulate these stem cells so that they enter into the blood vessels and they are available in the peripheral blood for a harvest. So we can have a rapid mobilization and a prolonged mobilization. And here we can see that these are actually the mesenchymal stem cells, and these are the hematopoietic progenitors, and the hematopoietic stem and the progenitor cells. And over the stem cells as well as on the hematopoietic stem cells as well as the mesenchymal stem cells, there are a number of receptors and a number of ligands which help these stem cells to remain in the bone marrow niche. But once we start mobilizing them with these growth factors, it increases the number of the neutrophils, as a result of which this STF1, the blue ones over here, they increase in the bone marrow environment, and these are also released by the neutrophils. These actually stimulate the formation of the neutrophils in the bone marrow, and the elastase enzymes which are released from the neutrophils, they act to inhibit the interaction between the stromal cells and the bone marrow niche, as a result of which there is increase in release of the stem cells from the bone marrow niche into the blood vessels, and as we see in this cartoon over here. So summarizing those steps, GCSF markedly enhances neutrophil production. It releases a neutrophil elastase and cathepsin G from the molecules of the developing marrow neutrophils. When released, these proteases cleave adhesion molecules expressed on the surface of the marrow stromal cells. Cleavage of the CXCR4 expressed on the hematopoietic stem cells and its ligand CXCL12 results in the release of the progenitor cells into the circulation. Prelixafor also has a complementary effect to it. and FDA approved as an adjunct to G-CSF for the stem cell mobilization, particularly for patients who are expected to mobilize poorly with G-CSF alone. So we need to understand whether our patient is a poor mobilizer or he is a good mobilizer, and accordingly use G-CSF or the combination with Perixafor. So next indication is acceleration of neutrophil recovery after bone marrow and umbilical cord stem cell transplantation. When transplantation is performed, a growth factor after bone marrow stem cell infusion significantly accelerates the neutrophil recovery by approximately 4 to 5 days. And there are meta-analyses which have shown this and proven this. Next indication, the improvement of neutrophil production in patients with delayed engraftment or graft failure after bone marrow transplantation. And this is a special indication of the GM-CSF. It is indicated in patients who do not achieve a neutrophil count of 100 by day 21 after transplantation, or whose neutrophil count drops below 500 following engraftment in the absence of relapse, often respond to a myeloid growth factor with improvement in neutrophil production. So most of the time we start after the stem cell infusion, we start growth factor in patients of autologous stem cell transplant from day 5 onwards. And in some centers, if the patient is stable, they may even defer it and allow the marrow to recover by itself. And when we see that by day 21, the patient is not able to engraft or he is losing his engraftment, there is a role of GM-CSF. So after the indications, it is important to understand what are the adverse drug reactions. So more than 10% is most common, 1 to 10% and less than 1%. So more than 10% adverse drug reactions, you find that there is abdominal pain, diarrhea, chest pain, peripheral edema, conversion to AML, fever, skin rash, metabolic disease, abdominal pain, this is again a repetition, sorry, Riker, bone pain. That is because when we stimulate the marrow, there might be periosteal reaction or the expansion of the periosteum resulting in bone pain and cardiac dysarrhythmias. Less than 10%, we have after autologous BMT, it is approximately 4%. Pericardial effusion may be there because of the capillary leakage. There might also be some lung injury, and that occurs in patients with BMTs. Less than 1% capillary leak syndrome. Frequency of this capillary leak syndrome has not been defined. There is anorexia, fever, malaise, cerebral hemorrhage, and sometimes stomatitis. So when we compare G-CSF with GM-CSF, what are the major side effects which are comparable over here is the G-CSF produces the medullary bone pain in approximately 30% of the patients, which has not been recorded or not been eluted in the literature by the GM-CSF. Osteoporosis occurs in 10% of the patients with G-CSF treatment. Headache and fatigue in 23%. Rarely splenic rupture and ARDS can occur with G-CSF patients. So many a times we are a little bit skeptical while using G-CSF in patients having lung infiltration or a pneumonia or if there is an ARDS-like feature. GM-CSF, flu-like illness characterized by fever in 22% of the patients, and this is one of the important side effects which has prevented many of the clinicians to use GM-CSF as an upfront. Myalgias, arthralgias 15%, fluid retention, dyspnea, and it should not be used concurrently with chemoradiotherapy. This applies for both. So this was systemic adverse events which was published in 1998, and here we can see that it is almost comparable, and this is 4 hours post injection of both the drugs. You find that there are some adverse events with the filgrastim, but it is quite less with the sargramostim arm. So there are fever and chills which may be attributed to the use of the growth factors, and since these are all cytokines, these reactions are maybe there, which occurs in also other cases of growth factor uses. So some of the literature which I have found out regarding the G-CSF versus the GM-CSF for stimulation of the peripheral blood progenitors, here you can see that when there were 3 arms, one using the G-CSF, the other with the GM-CSF, and there was the third arm which was a control arm. And in conclusion, they said that in terms of tolerance and mobilization of CD34 cells and leukocyte, G-CSF is superior to GM-CSF, but higher levels of uric acid and LDH and late decrease in platelets make monitoring of these parameters necessary whenever we are using G-CSF as a mobilization growth factor. So GM-CSF, this is the paper which mentioned that G-CSF was superior to GM-CSF. So the results also they have mentioned over here. You can see these are the three arms. This is the black dots are the G-CSF, the white ones are the GM-CSF, and this is the one where the controls were used without any growth factors. Here you can see that from day 0, the absolute leukocyte count is maximum on day 5, and after that it goes on decreasing. So mean course of absolute leukocyte counts determined before, during, and after a 5-day period of growth factor stimulation of healthy volunteers. They received 5 milligram per kg body weight of the G-CSF, and these arrows are the ones where the growth factors, every day the growth factors were given to the patients, and we find how it has increased the counts. Similarly, when they looked at the CD34 count, it was maximum on day 5 along with the TLC count, and after that the CD34 count decreased, whereas the mature neutrophil count increases after the day 5 of institution of these growth factors. So what about the other cell counts? As the name suggests, this is only the granulocyte colony stimulating factor, whereas GM-CSF is both the monocyte macrophage as well as the granulocyte colony stimulating factor. And as expected, when compared, these are the black one, that is the lymphocytes, then is the monocytes, and then these are the basophils as well as the eosinophils. So there is increase in when compared to the use of the G-CSF, here you can see that compared to the GM-CSF, the increase in the neutrophils as the basophils also increases, whereas in G-CSF, the neutrophils is much more marked in comparison with the GM-CSF. So number of days again to reach the target ANC, here we can see that with the GM-CSF, 500, 1000 and 1500 microliter are the dosage in which it was used against the standard dose of filgrastim, that is 5 microgram per kg, and the number of days to reach the target ANC is well depicted. It is almost the same, and the p-value was not much significant. Length of hospitalization and the mean duration of the fever. The duration of the fever was higher with the filgrastim arm and less with the sargramostim arm. The length of hospitalization, the p-value was not significant in this study. So this we have spoke about GM-CSF in delayed engraftment. Next is, this is important for us in India also as well as in US, comparison of the hospitalization risk and associated cost among the patients receiving sargramostim and filgrastim along with pegfilgrastim in patients with chemotherapy-induced neutropenia. And this paper suggests that the GM-CSF patients experienced a 56% lower risk of infection-related hospitalizations compared with filgrastim and pegfilgrastim patients. Infection-related hospitalization costs were 84% and 62% lower for sargramostim patients compared with patients treated with the filgrastim and pegfilgrastim respectively. So whenever we are using a product, definitely we have to see the cost, risk and benefit for the patients and accordingly decide with what factor to use for the patients. Then this is another study from the bone marrow transplantation 1997, which compared G-CSF plus GM-CSF versus G-CSF alone for the mobilization of peripheral blood stem cells. Many a time people do ask whether we can use both the growth factors together to bring about a higher CD34 count, and it concluded that there is questionable clinical benefit with PBSC products mobilized with G-CSF alone or with combination. And in these patients, wherever we use the combination, the adverse events from the drugs of using both the drugs is more rather than the benefit of having a greater amount of CD34 count. So this was another paper which showed the effects of granulocyte colony stimulating factor on bleomycin-induced lung injury. And bleomycin is mostly used in hematological malignancies for patients with Hodgkin lymphoma, both in the elderly as well as in the young adults. And this was the paper on G-CSF. Reminded it was not on GM-CSF, but on G-CSF. And these results indicate that the administration of GCSF to the rats with slight lung injury bearing no pulmonary fibrosis does not exacerbate the lung injury. Whereas the exacerbating effects of the GM-CSF seem to be associated not only with the increased infiltration of activated neutrophils, but also that means whenever there is an underlying lung injury and then we are administering this GCSF, there are chances of having a acute lung injury rather than having it just because of the GCSF itself. So there should be an inciting factor to have a lung injury along with bleomycin whenever you are using it for our patients. Another day-to-day clinical question which arises in our mind is nowadays all the lymphomas, whenever we are practicing and we are treating patients, we are doing an interim PET to assess the response to the chemotherapy for these patients. So this is a 2019 article, which is an original research article, and it says comprehensive analysis of the influence of GCSF on the biodistribution of FDG in lymphoma patients, insights for PET and CT scheduling. What should be the optimal time whenever we are using growth factors to our patients so that the interpretation of the Tuiveli score is good enough to give us an accurate idea about what is the response of the patient. So the aim of this study was to investigate whether an inversion of the liver to spleen ratio affects the Tuiveli scoring and what is the distribution of the FDG uptake. So what did they conclude? They concluded that neither the type of GCSF used nor the time elapsed between its last injection and interim PET-CT examination independently influences bone, hepatic or splenic uptakes in the interim PET-CT. That means GCSF use does not alter the uptake in this PET-CT when we are using it as an interim mode of assessment for the response of therapy. The major determinant for the occurrence of a bone or spleen hypermetabolism on interim PET-CT is the time elapsed between the chemotherapy and the examination, which should be maintained above 15 days. So this was important, and therefore the question of GCSF altering the signals is invalid. So since we are in the COVID era, and it is important because many of us are also managing patients of hematological malignancies having COVID-19 infection as well. And this was an article in Acta Hematologica 2020 published by Lazarus. The effect of GCSF and GM-CSF, are they different, and which one is better for COVID-19? So this was phase 2 Belgian multicenter study used aerosolized sargramostim in patients with COVID-19 related ARDS. Physicians used more of growth factors, and this article cites regarding GCSF induced influx of granulocytes in the lung, an effect not seen with GM-CSF. We had already discussed about the lung injury associated with bleomycin and pulmonary fibrosis if present earlier. So here also, since COVID-19 affects the lung epithelial cells, use of the GCSF has been shown to increase the influx of granulocytes in the lung, which does not happen with GM-CSF. And since we as clinicians are GCSF is more freely available in the market, most of have been using it. So it is like, it is a common practice to start with a GCSF whenever we find a patient having neutropenia of less than at least 1,000. However, there are no comparative clinical data in this setting, and there are concerns of increasing the lung inflammation or the hypothetical risk of increasing inflammatory cytokines such as IL-6 associated with an adverse outcome in patients receiving growth factors to persons undergoing conventional chemotherapy and hematopoietic stem cell transplantation during the SARS-CoV-2 pandemic. This is regarding patients of hematological malignancies undergoing the stem cell transplant and having a COVID infection and then cytopenias, managing them with the GCSF. So we have to be cautious in these patients, and in persons with lung infection or ARDS, GM-CSF may be a safer drug than GCSF. However, RCTs need to establish this. This was the only article which I found having a comparison of G-CSF and GM-CSF among the hematopoietic stem cell transplantation population. So whenever we are using this drug, we need to know what are the contraindications, and patients with excessive leukemic myeloid blast in both the marrow or in the peripheral blood should not receive this. Patients known to be hypersensitive to GM-CSF component products should not receive this. We should never combine chemotherapy and radiotherapy along with GM-CSF. It should always be given 24 hours post the completion of the chemotherapy, so that we do not, and the rationale behind is that this results in significantly higher incidence of adverse events, including higher mortality, higher incidence of grade 3 and 4 infections, and grade 3 and 4 thrombocytopenia. So there are some warnings and precautions as well. Caution in fluid retention, pulmonary infiltrates, heart failure, lung disease, cardiac disease, hypoxia, hepatic and renal impairment conditions may worsen with these use. Solution should not be administered to neonates due to presence of the formulation inside it, that is benzyl alcohol, which can cause gasping syndrome in the neonates. Discontinue immediately if blasts appear or there is disease progression. And a reformulated liquid devoid of the sodium EDTA is now available, which decreases these adverse events. Just these will be last 1 or 2 slides. I want to share my experience with the use of GM-CSF, and we use it. In patients, some of the patients, as per the indications approved by the FDA, but these 2 cases are a little bit away from. We have deviated from the approval guidelines because it was a 46-year-old male diagnosed as AML, developed fever and sepsis on day 11 of 7+3, initially managed with broad spectrum IV antibiotics, and febrile neutropenia protocol was followed for him. On day 15, he had persistent fever, hypotension, tachycardia with discharge thorax, showing features suggestive of bacterial pneumonia. Ball, Dunn, and Ramstein and culture showed Klebsiella pneumonia, which was pan-resistant. G-CSF started along with antibiotics. Patient remained hemodynamically unstable and required intubation even after starting G-CSF. Hence, antibiotics escalated to colistin, and GM-CSF was initiated after stopping G-CSF. So this was the table where we see that day 15 he started all the complications, started on G-CSF and broad spectrum antibiotics, still hemodynamically unstable. Day 19 intubated, and when the patient was intubated, since he had this infective focus in the lung, we shifted over to GM-CSF to prevent the other lung injury, and then we find that there is increment in this counts of the neutrophils and the recovery of the TLC, and then finally the patient was extubated on day 28, and then after that we discharged the patient, and he has completed his 3 cycles of consolidation as well without much of complications in the following 3 cycles. So this is one of our experience where we have stopped G-CSF and started GM-CSF, and the results have been fine, but I do not know whether it was because of the GM-CSF or the patient has spontaneously recovered from his neutropenia as the marrow has recovered by day 28. This is another case, second case, 53-year-old male. He is a Ph positive ALL, initially treated outside with steroids and imatinib, presented to us with severe cytopenia. Bone marrow done with us showed relapsed disease with a very cellular marrow. Performance was good. Hence, we started on BFM protocol with dose modifications and dasatinib 100 mg OD, thinking about the cytopenias he may land up with 140 dosage, to which he responded well with CHR on day 28, and the BCR-APL was 0.1%. During the phase 1/2 of the BFM 2002 protocol, he developed very severe cytopenia with TLC less than 500, following the first RSC block, but was hemodynamically stable. He received 5 days of G-CSF. Since he was a high-risk elderly relapsed ALL, we started him on G-CSF, but without much improvement in counts. Later, he was started on 500 microgram once daily of GM-CSF, following which he had an increment in counts after 3 once daily doses. And then after that, the patient has been tolerating the BFM protocol well, but on and off with neutropenias. So these were the 2 cases where we started with G-CSF, but then because of the low response in the improvement in the neutrophil counts, we had changed over to GM-CSF. So finally, we should know what are the differences between the two molecules. We have already gone through, just to summarize, that the GM-CSF has not only neutrophil recovery properties but also have monocyte-induced microbial as well as the antibacterial, antifungal protection also, and both of them can be given subcutaneously and they have their own indications. So concluding, both these are the most common types of hematopoietic growth factors used by hematologists as well as other clinicians and oncologists. These drugs are sometimes thought as being interchangeable, but this is wrong. In persons with lung infection or ARDS, GM-CSF may be a safer drug than G-CSF, as indicated by anecdotal reports and case series during the COVID-19 pandemic. Whether this is so, it can be answered by randomized clinical control trial, comparison trial, but unfortunately this may not happen, and this is mostly about our use, how we use it, and then documentation of these cases, which will help understand which CSF to use in which conditions. And we should definitely have a judicious use of the growth factors so that we give the maximum benefit to our patients. Thank you for your patiently listening, and I'll be happy to take up questions if any.
Thank you so much, Professor Priyanka. That was a fantastic review of the subject, very educative. I learned a lot, and I'm sure all the audience must have benefited from this lovely presentation together with your personal experience. So we have a couple of questions for you. The first question is about the efficacy difference between G-CSF and GM-CSF.
So there are, as I mentioned, that there are no head-to-head comparison trials, neither are there head-to-head clinical studies on be it the mice or the rats regarding which one is more efficacious. As I mentioned, the indications are definitely for the GM-CSF as well as for the G-CSF are very particular and have been laid down by the FDA as well as the guidelines by the ISMO and the ASCO. Based upon that only we will be telling it, but there are no head-to-head comparison trials.
Thank you. Second question is about, is there any increased chance of malignancy with GM-CSF?
Yes, sir. I had previously stated there was an article in which they had said that though previously it was thought that it will increase the risk of leukemia, but long-term follow-up studies have not shown any that sort of a thing that using these growth factors increases the risk of leukemia.
Thank you. The next question is, if the patient has febrile neutropenia without underlying hematolymphoid malignancy, is GM-CSF indicated?
Sir, we need to understand what is the cause of febrile neutropenia. If the patient is having an HLH and he lands up in febrile neutropenia, there are two schools of thought. Like in some cases, they say that in HLH, there is already an increase in the inflammatory markers which bring about this HLH, and having a growth factor or a cytokine added to it will definitely bring about a problem rather than a cure. So we have to understand what is the cause of febrile neutropenia. If it is sepsis related, there is a very good chance of using it and having the neutrophils getting up and the patient being cured. But in HLH, it is a contraindication in some of the studies.
Thank you. The next question is, what would you prefer in febrile neutropenia following AML induction or in any phase of ALL, filgrastim or GM-CSF, and why?
Not only in India, but also in US, and as I said, because G-CSFs are available in plentifully, many biosimilars and many pharmacological industries have G-CSF, and most of us are using G-CSF. Therefore, we are more prone to using G-CSF. The cost is one of the factors also which prevents us from using GM-CSF at the upfront. So both of them are equally good. You can start with both, but as some studies have shown that G-CSF has a faster neutrophil recovery, many of us prefer to use a G-CSF.
In the AML induction phase, which day do you start G-CSF or GM-CSF?
For pediatric populations, we're trying to prevent the use of GM-CSF. Even in the young adults, if they are hemodynamically stable but having running fever, cultures are there, we find a growth in the cultures which is sensitive to the antibiotics, we may not start the growth factors at all. We would try to prevent because this is a curative intent. The therapy 7+3 we are giving for a curative intent. But in patients like elderly, suppose it's a 50-year-old male or a female, with some underlying comorbidities, I would like to do a marrow at day 14 and then start. Or if the patient even at day 10 or 7 is undergoing hemodynamic instability, we do a marrow and then start growth factors.
Thank you. The last question is, if the patient is on these growth factors and blast cells appear, how do you differentiate a relapse from these factor-induced blasts?
The factor-induced blast, we do not say them factor-induced blast, but these are the hematogons which come up to the periphery from the bone marrow in cases of recovering marrow. But if there are blasts and the counts are low, it's very difficult. And in those cases, in case of doubt, you definitely have to go for a marrow to look at whether these are hematogons or these are blasts.
So that was the last question. Professor Priyanka Samal, thank you once again for a lovely talk. We really learned a lot. And over to Emcure now for the post.
Thank you, sir. Thank you so much, sir. Thank you, Emcure, for having me here.
I hand over to Dr. Arvind now.
Thank you, sir. So before we end the meeting, I think we should have the post-webinar poll, understanding what we have learned from the speakers. So now there would be 5 questions shown on your screen. Please select your response and click the next button. And it's perfectly fine if you don't remember what you have clicked in the pre-webinar poll. These are exactly similar questions. So over to you for the audience to respond. Yeah, thank you so much for the response in the post-webinar poll. It would be certainly insightful. With this, now I take the honor and my pleasure to invite our cluster head for the oncology in Emcure, Ms. Manisha Sonavlekar. So now I hand over to her for the closing remark and vote of thanks. Over to you, Manisha.
Thank you very much, Dr. Arvind. On behalf of Emcure, I would like to thank Dr. M.B. Agarwal, our program director, who coined this program to drive this such a meaningful discussion. And needless to say, our esteemed speaker, with national as well as international, who made this discussion a scientific feast. Of course, Emcure remains committed to such scientific engagement, dissemination of updates, and educational endeavors. So I thank everyone on this occasion and dissemination and interactive program. Stay safe. Thank you all.
Thank you, Manisha.
Thank you so
on my
much.
behalf and on behalf of the speakers, I thank Emcure for giving this opportunity to us, for joining hands with you. Mumbai Hematology Group is always there for academics. And thank you so much once again, and good night.
Thank you, sir.
Thank you so much, sir. Thank you, Emcure.